Hi, everyone. So today's webinar is going to focus on sustaining learning health systems research and rehabilitation. We are delighted to have this opportunity to engage with leaders from several of LeaRRn's health systems partners. As I introduce each presenter, I ask that you please turn on your camera. Just before actually I do the introduction, the format of this section of the webinar, we will have 6 questions that the panelists will answer. We have select panelists answering each question. If you, as an audience member, have a question or a comment, please use the Q&A function. And at the end of the 6 questions, we will have some time for me to review those questions for discussion for some additional comments from our panel. So with that, I'd like to start by introducing Dan Chiolik. He is the Associate Vice President of Therapy Advocacy with the American Healthcare Association / National Center for Assisted Living, ACA-NCAL for short. In addition to therapy policy advocacy, he leads or supports multiple ACA-NCAL advocacy efforts around payment, regulatory, quality of care, and health information technology policies. Mr. Chiolik also facilitates academic research on clinical outcomes in member communities. Michael Friedman is a strategic programs director at Johns Hopkins Medicine and an assistant professor in the Department of Physical Medicine and Rehabilitation, Johns Hopkins University School of Medicine. He directs the Johns Hopkins Activity and Mobility Promotion Program and is the director of the International Rehabilitation for the Sheikh Khalifa Stroke Institute. Mr. Friedman leads knowledge translation activities for physical medicine rehabilitation globally through Johns Hopkins Medicine International. Tim Marshall is the Senior Director of Analytics and Insights for Ivy Rehab Network, which consists of over 650 outpatient physical rehabilitation clinics for both the adult and pediatric populations across 17 states. Tim is responsible for leading the organization's strategy and deployment of data analytics, transforming strategic insights into actions that improve the patient experience, care quality, and drive business growth. Karen Maddie is the Senior Director of Clinical Operations at Boston Medical Center, where she oversees the clinical and operational leadership of physical therapy, occupational therapy, and respiratory care services. In recent years, she has focused on implementation science research. Her ongoing collaborations have led to the successful implementation of the Johns Hopkins AMP program at Boston Medical Center. She is a member of the Massachusetts Health and Hospital Association's Continuum of Care Council and serves as an adjunct clinical instructor at Boston University. Bob McCall serves as Vice President of Rehabilitation at Intermountain Health. He has over 29 years of experience in complex hospital systems as a physical therapy clinician and administrator. He has extensive experience in network and program development, employee retention programs, and productivity enhancement programs. He has served in leadership roles across a broad spectrum of healthcare settings, including academic medical centers, long-term acute care, skilled nursing, and inpatient rehab settings. Prior to joining Intermountain Health, Mr. McCall was at Spaulding Rehabilitation Network for 19 years. Mark Schmaler is a practicing occupational therapist and assistive technology professional, serving as a director of the Center for Assistive Technology at the University of Pittsburgh Medical Center. He is also an associate professor and vice chair for clinical services and policy in the Department of Rehabilitation Science and Technology at the University of Pittsburgh. His research focuses on clinical service delivery to inform practice and policy for wheelchair mobility and related assistive technologies. He also works closely with local, national, and international organizations as an advocate for appropriate access to assistive technology devices and services. Carla Tierney Hendricks is a research fellow and speech-language pathologist in the Department of Physical Medicine and Rehabilitation at Spaulding Rehabilitation Hospital and Harvard Medical School. She is also the Director of Health Systems and Implementation Science Research in the Rehabilitation Outcomes Center at Spalding. Dr. Tierney Hendricks' research aims to optimize long-term outcomes for individuals with aphasia and other cognitive communicative disorders by improving access to effective rehabilitation services and enhancing the adoption of evidence-based practices. So welcome, everyone, and we thank you for being here today, and we're looking forward to an interesting discussion. So with that, why don't we start with the first question? What challenges has your health system experienced in pursuing learning health systems work, and what strategies or approaches have you used to overcome these challenges? So Michael or Mike, do you want to start first with a response? Looks like you're on mute, just FYI.
Just starting off right away for all of us. So now that I'm unmuted. So I think one of the biggest things is to bring together the right people and to focus the work. And so when I say that, and this is at Johns Hopkins, but I'm sure it's similar to other organizations, there's so many stakeholders, so many ideas, so many questions. On the research side of Johns Hopkins, we have a number of people that are focused on perhaps certain grants or certain questions. And often when we then work on our frontline teams, their questions can often be what we call P3s, personal passion projects. And those things don't always align with the priorities and strategies of the department, the hospital, the health system. So for us, the first step is alignment of what are our priorities and what are the questions we're chasing after. And those are usually driven from the clinical operators. We totally want our front lines to be engaged, but at some point when we're really limiting the questions, we need that to come from clinical operations leadership. The second partner that's super important is informatics and analytics. I will say we are where we are because we use Epic. We know there are other groups we work with through our AMP program globally, Oracle, Cerner, et cetera. But leveraging the EHR is a must. Like, that's where people work. That's where you're going to systemize content and data and need to just be wizards at leveraging the EHR from collection, aggregation, reporting, and evaluation. And then the last part is truly building in, and again, we have some of this in our culture inherently, but building in budgets, resources. We even have residencies and fellowships that allow for time and quality improvement. Building all that effort and time that requires, we need evaluation, analysis, and course correction for these questions, not as a nice to do, but as a need to do to make wise operational definitions. So those are the big things. And, we mentioned challenges that didn't happen overnight. And if I had to pick the biggest one, it's always getting to a level where you're not intimidated by the EHR, and in your systems, when can you advocate and have equity that what you're asking for becomes something that takes you a couple hours to get to yes and not 6 months to get to yes.
Thanks, Michael. Karen, do you want to add to that?
Sure. Thanks, Janet. Hello, everyone. It's wonderful to be here. Michael, you took all of the large buckets, and so to get more granular for us at BMC, I would say I would add to the list is like simply logistics. How do we do a data use agreement with another person who works in a different institution, different health center? How do we get in queue quicker for the clinical data warehouse to align our variables and allow time for our pull? Though those were two things that bubbled to the top that should have been more simple for us. And so we had to do workarounds, and we found our ways to get what we needed to get. So I would add those in. Ways in which we were successful is partnering with our quality and patient safety department, who has expertise in navigating data. So they helped us in that path. A second approach that we took at BMC, as we actually have 4 scholars that have gone through this program, is we've partnered each other, right? You learn a little bit more each and every time through this network. So I was appreciative of the 5-year length of time and the multiple opportunities to have scholars, because we built relationships, took the wins, and passed them forward.
Great, thanks, Karen. And then finally, Bob, do you want to comment?
Yeah, I sure will, Janet. Thanks. Really great comments by Mike and Karen. Addressing, I guess, what I would call, first off, a culture of the organization that supports this sort of work. And I'm fortunate enough at Intermountain Health to work in an organization that certainly promotes and supports discovery and measurement, reporting. But beyond that, if that's not the case, it's really critical, as Mike said, to tap into what the priorities are of the senior leadership of a hospital or an organization, to be sure that the work we're doing is meaningful and has connection and can show evidence that really drives towards those priorities. On an individual level, there are still clinician hearts and minds that need to be won over. And that important work to me is really about identifying what motivates against maybe some competing factors of time and attention that most clinicians experience. In our organization, we have a very strong career ladder program that has elements in it that reward and incentivize individuals to participate in LeaRRn projects and other outcomes types of work that can result in promotion and title and some compensation enhancements that are critical in supporting participation in LHS work. I'd probably just add one more now, and that is, to add again to the whole medical record. We are in the process of transforming from our current large medical record into Epic, and that will result in some improvement in the way we collect data, the way it's disseminated, the way it can be consumed. But key for us was partnering with data and analytics expertise to help us build out and customize the types of reports to make it easier to contribute to, that isn't too burdensome, and frankly, easy to digest and to review and understand for the larger population. Most of these health records don't come out of the box ready to roll, as far as I'm concerned, when it comes to supporting learning health system work, but with a careful partnership with analytics expertise, I think it's very achievable.
If it's okay, I just pile
Yeah,
on.
yeah, please comment. We still have a little bit of time.
I'm going to say this is super important. I think a lot of organizations have strong clinical operators. I think they're searching for that research piece. I want to pile on what Bob said, which is we are lucky enough to have organizations that we work with outside of Hopkins. We see gaps and strengths around that clinical informatics function. And so we have a high-level clinical informaticist who is a physical therapist. I've seen nurses do it. I've seen physicians. But I really see this triad between the clinical operator, the health services researcher, and this informatics function, which is clinical. There are other informatics functions, but clinical informatics specifically, that is where we've been able to really drive productivity on health services research questions.
Great, thanks, Michael. So if folks have more questions about this, hopefully we'll have some time at the end. We're trying to kind of keep on schedule with the questions, so it's time to move on to the second question, which is describe the infrastructure that you have in place to support LHS research, and what does your health system need to expand to be able to support LHS research? So with that question, why don't we start with you, Mark Schmaler, please?
You need to unmute, I think.
You're absolutely right. Sorry about that. Thanks for having me. I'm unmuted now. I was just saying that I have a unique situation with our clinic in that we work with people who have severe disabilities and very complex assistive technology needs that isn't necessarily a profit center by any means. So clinical outcomes and downstream benefits are really what we try to focus on, at the same time making sure that our clinicians are as productive as possible. So, what do we need is, first of all, high level organizational support. We are fortunate that we are an academic program as well as a UPMC based clinic. A lot of our clinicians are also faculty, so they do have time carved out to engage in clinical research. Um, but sometimes there's competing priorities with this, that there's a perception perhaps on the medical center side that the researchers are draining resources for their research agenda. And on the clinical side, there's also a perception that when researchers do come in, that it can distract from other priorities. But we have been fortunate to do that. One thing that we also have going for us is, as I was mentioned before, our electronic health record. We have a very strong health information management department that also collaborates with us. When we first, when Corey came on board, we were in the middle of transitioning from hospital-based clinic to outpatient rehab clinic, which created some significant changes that maybe we weren't ready to start doing this kind of work, but we were fortunate that having existing data sets that we've developed over the years in collaboration with other partners around the country, mainly other medical centers and also industry, contributing data to a registry, starting to look at those analytics, and having someone like Corey come on board that has that health economics perspective. We're able to start looking at what are what is the return on investment related to this clinic, and also working. The other part of this is having a health plan built into our health system that's also interested in what is this expensive technology doing for long term, and that's been very helpful. So I think with our second LeaRRn Scholar, we looked at it a little bit of a different strategy. This person had a very strong background in health informatics, who's also an occupational therapist, very familiar with the Epic system and how to build out, templates and other data collection uh, strategies. So what we learned from that too is that you're able to get the information or the data that you need to start looking at the benefits and outcomes of your interventions, but doing it in such a way that doesn't add burden or extra work to the practicing clinician. So what we're working on now is exactly that, is taking our existing infrastructure of documentation and coming up with strategies to extract that data so there isn't duplication. And I think that really works well with busy clinicians, that they are contributing to this health systems research, but it's not adding extra burden to their clinical routine, and it's helping to sustain their clinical quality of life.
Okay, thanks, Mark.
Thanks.
Tim, you want to comment?
Yeah, I think Mark touched on a lot of great points, and the structure that has to be in place. I mean, you have your people side, which, people starting from leadership within the organization being supportive of the initiative in order to allow for time to be dedicated to the management and oversight within the organization to partner with our LeaRRn Scholar. You also have to have internally your SMEs who are going to help support LeaRRn Scholar, as well as the technical folks who are going to be able to extrapolate the data from the data warehouses, from the data lakes, and model it out in a form that can be utilized by the LeaRRn Scholar. If that technical personnel is not there, then we run into a lot of issues or roadblocks in trying to access that data. With that, I mean, that also speaks to the technical resources you have to in place. The data has to be in a place. You have to have the internal architecture or the internal pipelines to be able to get at it, to be able to free up the needed data that can be then leveraged for these projects. And then there's the process side. I think I spoke, just getting some of those data use agreements. There has to be an efficient process set up between LeaRRn, between the SMEs, the project stakeholders, and legal to make sure that we can move through that process efficiently so that there isn't a delay in getting the LeaRRn scholars started. And that those first couple times that you have to navigate that process, it can be a little tricky. And so any sort of pre-planning that can be done to make sure you have the right people, the technical, and then the support process in place before the engagement will certainly help make for a much more efficient and pleasurable experience from both sides.
Great, thanks, Tim. And then Karen, do you want to?
Yeah, it was really nice to hear you both, Mark and Tim. I would say, as I think about anything additional to add, I think what we learned at BMC is that this is quite a moment for the rehabilitation services in general. To have a network like this where we are leading research from the front is understated, I believe. And how that came to light in our service line is that research really starts primarily in the medical school, physician first, physician driven, and the rehabilitation services are also an adjunct or an add to the intervention. And so this really highlighted the need for infrastructure at the rehabilitation service level to drive from the front. And so one ways in which we did that was reach out more and more to our BU Sergeant faculty members that are more knowledgeable in this area, BU public health arena, and our physicians that drive research to learn to begin to model practices to really be able to lead from the front, which is new and appropriate and very exciting to do.
I think we have another minute or two. Do any of our other panelists want to comment?
Janet, I'd love to respond to something that Mark said that really triggered some thoughts in my mind, mentioning the healthcare plan, the health plan that an organization has. For example, we're fortunate enough at Intermountain Health, we've got a health plan with over 1 million covered lives. And I think it's easy to forget how influential and how important health plans wake up every day wanting to study the outcomes and what impact that has on patients, whether it's access or affordability or improved outcomes. So whether it's direct partnership with your own health plan or being able to reach out and really partner and understand what the payers would be impacted by the critical work that we're doing before we finish, have them in the planning stages of the types of work that they would support and that will really have meaningful impact.
Yeah, nice follow-up. Any other comments? We can move on to the next question. I think we're kind of good on time. Hey, Carrie, you want to put up the next question? Okay, our next question is, what is the feasibility of bringing in external embedded researchers and what are the challenges? And I think we've hit upon some of these already, but it'd be nice to hear from some of our other panelists and see if there's other thoughts about this. So Dan Cholik, you want to start?
Sure, thank you, Janet. Yeah, this is a great question, and I think from a perspective of the nursing home and assisted living sector, and it's definitely feasible, and we've demonstrated that. We are currently supporting and hosting 3 embedded rehab research projects within our membership organizations currently, and I think there's an opportunity to do more. It's interesting, ACA-NCAL is not a formal health system per se, even though we're a partner as a health system partner. We are a National Federated Provider Association, but we represent over 15,000 members, including skilled nursing facilities, assisted living facilities, and residences for individuals with intellectual and developmental disabilities. As such, we don't directly manage these organizations, oversee the direct care and quality improvement efforts that some of the other panelists have talked about. They have to focus on, but we provide education and policy and advocacy support. And part of that support is to be involved in research that helps advance care in our sector. So we have been participating gratefully with the LeaRRn and the AHD health system as a partner. And Part of our activities, we help establish our rehab research priorities within our membership, as well as facilitate the matching of researchers with members in our organization that seek to advance their care quality and outcomes. We also, as an national organization, support and host the National Institute of Aging funded long-term care data cooperative, which is a collaboration among providers, stakeholders in academia, government, and private sector. Therefore, we have a potential data source platform for rehab researchers embedded in our members to have access to linked patient data sources beyond the information contained in the organization's EHR and billing system, so that there is ability to expand this, which we think is a great opportunity that we're looking forward to maybe advancing as we go on in a later question. Our challenges are that we do have a diverse membership from large multi-site corporations to small independent operators with a single or a small number of SNFs. And many of these have varying levels of digital maturity that could support research projects. For example, some of our larger organizations may have facilities with different and incompatible EHR platforms, typically with various mergers and acquisitions. So some of the talk in the prior panelists talked about when they're switching EHR systems. You imagine trying to do rehab research, and we have one researcher that is dealing that with a organization that has multiple rehab platforms with their documentation. So it creates additional layers of complexity. We will have to say that most of our SNFs are not affiliated with a health system formally or a university and may not have familiarity with many of the research legal documents and IRB process. And that has created it creates delays in how quickly you can kick off the project itself, because everybody's learning the basics of how to do research in many of our organizations that we represent. Additionally, a significant portion of our SNFs outsource their rehab services to a third-party contract therapy organization, which may have their own documentation systems. And that adds layers of complexity for researchers, particularly when you're dealing with data use agreements and other things. Finally, and also who's leading the research activities? Is it the SNF or a rehab company? So there's a number of complexities there in some organizations. Finally, there remains notable post-COVID staffing shortages in certain markets that limits the capacity for some of our facilities that might be interested to take embedded researchers until their overall frontline staffing care stabilizes. And hopefully within the next year or so, we'll be able to have more opportunities to have embedded researchers in our members. Despite these challenges, there is current interest. I was speaking with someone the other day, and potential in our diverse membership to consider opportunities to accept embedded rehab researchers that could help them improve the quality of care and outcomes in their organizations. Again, thank you, Janet, for that question.
Great. That was very thorough. Thanks, Dan. Carla, do you want to comment?
Yeah, sure. Thanks so much for having me. So we've been fortunate at Spalding to have 4 learning health system scholars with us, working across a variety of different projects. And so many people have already highlighted some key factors that are important to making that a successful relationship. Key is really that the health system is committed to learning health systems research. So having that cultural buy-in, it is a team science. Another factor that has been really important for our team at Spalding is having an internal group or internal individuals that are committed to partnering with that researcher. Because having that internal infrastructure to make sure we're connecting that scholar with the right individuals, like clinical informatics is huge, understanding the clinical workflows, because every context is different. Bringing in the administrators, making sure the research aligns with the priorities of the health system. So at Spalding, we've had the Rehab Outcome Center, which has really focused and have been a hub to be a conduit for that outside researcher to come in, and also connecting to existing research and also the clinical needs of the health system. One of the challenges that I've kind of experienced working with some of the scholars is just making sure we're balancing the needs of the research scholar with the needs of the health system. So in research, we have different forms of currency. We need publications, we need to apply for grants. So making sure that we're still retaining the rigor of the research while also kind of responding to the dynamic needs of the health system. Sometimes priorities change. the research can be messy because you're working with clinical real life data. But I think we've done a really nice job of integrating implementation science methodologies to really frame and add rigor to the work. And the scholars have really done a nice job, progressing the work of the health system, but also keeping in mind what are their goals in terms of their research careers. So we've always been really sensitive to considering that with our scholars.
Great, thanks, Carla. Let's see. Some good points brought up. Tim, do you want to add to that?
I think, everybody's provided some really good insights here. And I think that feasibility really goes into that pre-planning process as well. I mean, it's before officially engaging, there needs to be a time where the organization takes a step back and makes sure that they have everything in place in order to facilitate a successful engagement, not just jump right in, but pre-plan, make sure you have the right people, the technical, and the processes in place first.
Right. Anyone else? I think we might have a minute or two before we go on.
I think I could add something more granular, and this is true with LeaRRn, but we've been doing embedded researchers for a long time. And I'll just say appointments, data governance, and IRB, there are consistently changing policies around them all. And the structure of how we can have embedded people do certain things and not do certain things is Johns Hopkins faculty, and figuring out how to get there. And some of that goes to what Carla mentioned with regards to partnership and kind of who's the mentor and who knows the map of Hopkins to make life easier, or the other organization. And then the flip side is this is about people. And the other thing is splitting effort and accountability. And so the embedded researcher has other effort, other jobs. And we've found as the embedded researcher has more effort to your health system, that's easier because you control more of that accountability. But if it's a small percentage of effort, that is something that needs to be managed.
Yeah, I think that's a good point. Just as far as balancing the expectations, considering especially with the LeaRRn scholars, the modest amount of funding that they got for that. And then I think you brought up a good point, Michael, just with the idea of how Hopkins in particular has kind of navigated the embedded researcher. Some is to give them appointments, and which deals with a lot of the data use issues, which is one model that's been successful. And I know, Tim, you guys send computers that are from Ivy to the embedded researchers to use, so that's another way of kind of navigating some of the data issues that are have been, I think, the biggest barrier to the work of the scholars. All right, great, thanks. This is great input from everyone. Why don't we go on to the next question? Okay, can you talk about other ways that you have collaborated with academic partners outside of LeaRRn? And Michael just talked about that a little bit, and whether these partner models could support learning health systems research. So Dan, I have you up for that again, if you want to start us off.
Sure, thanks. Yeah, I think at first when we first participated, it was sort of like how do we help facilitate embedding researchers in our communities. But I think as we learn more about LeaRRn, and we'll learn with our researchers as well as the other researchers in the program, we developed relationships, connections for other things that I think help advance broader opportunities and academic and research opportunities. Some of the things we've had during our tenure as a LeaRRn Health System partner is that outside of the LeaRRn project, we participated in supporting various LeaRRn rehab researchers and obtaining grants for unrelated projects that are ACA and CAL member priorities. So some of those things have either been approved and not started, or just started, and so that we're excited about getting that out there and getting involved in that so that we can improve care and facilitate that opportunity for researchers to work with our organization to make sure that the research aligns with the priorities of our membership. We've also been able to support successful efforts to publish original research articles and poster presentations related to our embedded researcher activities, as well as other LeaRRn research projects. And so again, it's not just this project, the relationships have expanded beyond it. We've also participated in various symposia related to identifying research priorities and leveraging technology. And we wouldn't have had those opportunities to do that without our linkage through the LeaRRn project. So again, we appreciate that. And I wanted to finish up here talking about, I mentioned early the LTC data cooperative, and I think we want to create a platform that facilitate researchers coming to us. And part of that cooperative to do that. And part of it is to link the data that our members make agreements with to donate their data from their EHR system. So they're our predominant vendors in our sector are Matrix Care and Point Care, and they're participating. So we have the opportunity through this process to actually merge that data that's not totally aligned within this project cooperative. And the data serves four purposes for researchers to consider approaches. One is healthcare operations and population health analytics, public health surveillance, observational and comparative effectiveness research, and clinical research studies. And again, for grant-approved research studies, not only can this EHR data be obtained from the provider members that donate it, but we have an agreement with CMS, Center for Medicare Medicaid Service, via the NIA data linkage program to merge that data with other CMS administrative data through this process. So that not only do you have the issue of, what if you don't want to do an outcome study? We have a current project that has looking at outcome studies because they do SNF care and outpatient therapy. And so they can analyze the patients that got SNF care and went to their outpatient therapy provider to look at the outcomes, but they have a limitation because they can't compare to if they went to outpatient therapy any place else. This would allow that opportunity to do outcomes research regardless of where they went, because they went to a Medicare provider of any sort. They could be linked here. So there's opportunities there that were not available through other methods. And again, we done this because we have other projects with partners as well. We're partnering with Brown University School of Public Health in this project, and Acumen, which is a CMS contractor that is the independent organization that merges this data and it addresses all of that privacy and all those other data use agreement things that provide the data protections, but also facilitate using more current data to provide outcomes analysis versus the more latent data that you would ordinarily get from CMS when you're trying to do this stuff. So there's a great opportunity there we're excited about. And I'll stop there because I've probably taken more time than I should have.
Great, thanks. Thanks, Dan. Carla, you want to go next?
Sure. Yeah, so at Spalding, we're really fortunate to have academic affiliations with Harvard Medical School and then the MGH Institute of Health Professions. So similar to what Karen mentioned before, that historically there's been more kind of research and collaboration from the PM&R side, from the physicians. But really now, as the MGH IHP is growing their doctoral program, they have clinical doctorate, they have now health science program growing, we're able to continue to build those collaborations in doing rehabilitation research. So at a small scale, my colleague and I have been doing a lot of partnership work. I have a colleague, Megan Schleep, who's on faculty at the IHP, and we've built a nice process of bringing in master's level students to do thesis projects with our clinical teams to kind of chip away at some of those smaller scale problems as a model. But we're also now looking at how do we create a broader infrastructure for this, and in two ways. So we have a clinical scholars program at Spalding that we're looking to now revamp, where we have clinicians that are interested in doing clinically oriented research or quality improvement projects, but bringing in faculty from the MGH Institute of Health Professions to mentor these students and also to maybe ask their own research questions as well. So we're looking to kind of build that infrastructure with some leadership at Spalding, as well as some of the faculty at the IHP. Another avenue we're also looking to pursue is, getting grant funding for training grants around implementation science. So we can actually have doctoral students, postdocs, collaborating with Spalding clinicians and researchers to do this type of work. So I think you can think about it as a smaller scale of do you have a partnership with someone in an academic institution as a health systems researcher, and then bringing in students and mentoring students do that work on a very small scale, and then creating larger infrastructure where you have more at the program level, kind of bringing in researchers and connecting, building those collaborations?
Great, thanks, Carla. So yeah, we've had two very different settings with Dan and Carla, and then I was going to go to you, Tim, because you're, Ivy's a, kind of its own thing and own organization. Can you comment on some of the other academic partnerships you've had in addition to LeaRRn, and what we might learn from them?
Yeah, so using kind of the infrastructure that we've set up as part of our LeaRRn engagement, it has allowed us to, when I've come across other academics or academic researchers who have similar interests to some of the questions that we kind of have on our board that we would love to be able to answer, but just don't have the capacity to do so. We've kind of leveraged that to then create these partnerships, because we have a ton of data, as we all do right now, that we have a ton of data and a lot of questions that we'd love to have answered and just may not have the current internal capacity to do so. So as Carla mentioned, I mean, it's leveraging some of these other external partnerships to bring capacity into your organization, but also provide those individuals the opportunity to learn and engage in this type of scholarly research that can be kind of symbiotic for both organizations and individuals we've done that quite extensively over the past couple of years. A couple of faculty members from UPitt we've engaged with to help move forward certain things that they're interested in collecting data on, and we have the capacity to help support them, or we have other data that aligns with their questions, and it's just been we've engaged in other partnerships that way.
Thanks. I think this is an important question. Does anyone else want to comment? I think kind of sharing ideas, and again, this kind of relates to the idea of sustainability of this work, since LeaRRn's going to be sunsetting soon. Do any of our other panelists want to comment before we go into the next question? No takers. Okay, all right. Well, why don't we go on to the next question then? Can you discuss ways in which you've been successful in getting leadership support for learning health services research? What advice do you have for other health systems? And again, I think this has been kind of a common theme of trying to kind of bring rehabilitation, up in the laundry list of health systems issues and problems that they want to address. So who do we have slated for this one? Michael, I have you down to comment on that.
Yeah, sure. I mean, so the first thing I do, and remember, I'm a clinical operator. My job's a little different now, but I oversee rehab similar to what I think Karen and Bob do. And my first thing is I don't call it research. This is just business. This is part of just evaluating and making strong business. And I see some heads nodding. I sit in meetings all day long where there's $20 of ask for every $1 we have. And we are making horrible decisions. And I say not we, I mean we being Beyond Rehab, everyone. We are making horrible decisions on business assumptions with zero data. And so that's the first part, is just we need to make better decisions. The second part is we always think like getting to yes. There's a qualitative and a quantitative argument. Okay, so hearts and minds here. One's telling stories and one's data. The first thing I always do coming in the door is make us feel horrible. At Johns Hopkins, that's a Napoleon complex. That's saying, this is standard of care at Mayo, Intermountain, and Cleveland Clinic. How can we not be doing this, right? And then the next piece is demonstrating all the places that we have done great work. Our ICU program in 2008, reduction in readmissions, mobility, and our program that's been disseminated other places. And using your language, I take this from Mike Martin at Ohio State. He calls it the love language of your organization. For many groups, that's value-based healthcare. And so Bob mentioned payers, but on the hospital side, that's quality safety, that's the length of stay, that's throughput, and speaking those terms, which do equate $2, and not being afraid of talking about those dollars and realizing that rehabilitation, and I think Karen said this, is a major driver for some of the problems we have as an opportunity that has not yet been innovated. And I will tell you, we just had a big one around length of stay where they invested in a number of therapists because we demonstrated there was a cohort of patients that if we just saw them a little bit more, we can get them home instead of placement, which is a big deal when you're 98% capacity in a hospital. But that was all done with research from our health services team. So that's what I would encourage. And then once you have equity in what you've done, it's a lot easier to go back the next time and always build into that plan. You need analysis and evaluation. And now you might start getting a couple projects that start to build effort together for someone to work on it. So that's kind of the way we've been doing it for a long time. So Janet, I'm sorry that I just said to not call the research. But that's my approach.
Yeah, no worries. Bob, you
Well,
want to follow up with that? I know since he was, Michael was referring to some of your comments.
Yeah, I'd be glad to. I'll try to match Mike's enthusiasm and energy for the question about engaging our leadership and say, quite frankly, we've adopted an approach of obsessing with learning and being part of what the organization's larger strategy is. It's the only way to make it work, is to pick our heads up and be sure that we're connected to that. I think of Samana's example of addressing falls prevention and how well that connects to our proactive care strategy and getting out in front, even though it's an investment that's required and it's time, you've got to prove the point ahead of time. But it's that sort of alignment to what the larger strategy is of the system that is so critical in getting leadership buy-in. Two brief practical points. We have built in the cadence and expectation of an opportunity to regularly report on metrics and outcomes and performance. Every week we rotate through so that leaders from senior level down to frontline contributors, it's just business, as Mike said. It's what we do. It's not a bolt-on or an occasional invite to have a special topic. It's part of every single critical meeting to be focused on what the performance is and what those outcomes are. And as sort of a final practical point, it's become part of our both leader on the rehab level as well as our executive rounding. When we do what we call step back reviews, it's not just making an appearance and it's not just friendly, how's the morale? That's important, but it really is driving into the questions. Let's share your performance and let's share how what you're studying and what you're measuring and what you're doing is improving that so that we as leaders can help remove barriers or understand our investments or understand our priorities a little bit better. All of it intended, once again, to treat this as just part of the business and not a discretionary component that sits off to the side.
You. And then I see your hand up there. I'm just going to let Karen go and then I'll get to you.
I don't even know how to keep going after
how to follow that.
I think I align, quite frankly, quite a bit with what was just said. The only add value I could say is I believe that there are a lot of gross assumptions about the rehabilitative services in general. There's a lot of assumptions, and I don't think we're there yet with really quantifying our work. And therefore, that leads systems and executive leaders down assumption pathways instead of down data-driven informed pathways. How can we, what is our practice and how are we impacting the patients, the system, the lives that we cover? And so, it says, what advice do you have? I would say if you're a figurehead in your institution is to listen more to the problems that your system is having with patient flow, with bottom line, with length of stay, with discharge placement, with any of your issues. Just listen more, because I think that you will find rehab on that page somewhere. And then your obligation as a leader head is to utilize the amount of academic and scholar and expertise in these types of networks to research it or to study it, I say, and then to bring back the data. That way the system can make an informed decision. That's how we've gotten to yes, is we've saved some of our bigger questions that are system problems, and applied a large network like this to the problem. Because there's so much brain power here, right? Like bring your biggest problem to a network like this and then impact your entire system. So that's what I would add.
Dan?
Yeah, I think the secret sauce of the learning health system model and what LeaRRn has done with the researchers is the approach that people have been talking about. It's going to talk to the communities, talk to the providers, and ask them what your needs are to do those improvements in care you want to do, and try and figure it out that way. I think traditionally, a lot of frustration traditionally had been is that researchers came in and said, "Here's my project. Can I fit this square peg into your round hole of your organization?" And everybody got frustrated. I think our experience with the three researchers we've been working with has been positive, that the listening part that everybody's talking about is a thing. What is the problem they're trying to solve? Can you have the tools to bring the research tools to figure out how to solve those problems with data, or with how to manage a new treatment approach with data that fits into their model, which I think collaboration makes people more willing to participate and support those things as we get on and move forward. So again, I think that's a secret sauce, is that listening part that Karen mentioned.
Thanks, Dan. All right, last question. So we have some time, hopefully at the end, for folks to ask our panel some questions. Our last question is, how has your learning health system model evolved throughout your participation with LeaRRn, and how do you envision continuing to advance and sustain it? And Mark, we'll start with you. I know we haven't heard from you for a little while.
Yeah, I've been saving it for the last question, so thank you. This has been just a wonderful experience. I'll just start out by saying that um, we still, even though our first LeaRRn Scholar is no longer a LeaRRn Scholar, we do have a second one, but no one has left the island. We still meet on a weekly basis. It just has sort of grown organically. And as we meet, so we have partnerships, with Ohio State at Wexner. There's people contributing data from all over the place, sort of outside of LeaRRn, but bringing the LeaRRn scholars on, and then the LeaRRn scholar brings health economics to the table, and then he brings invited an intervention, implementation scientist to the table, and then we're all at different institutions where we have trainees. So I think, like what was being said at Spalding, we all have capstone students that need projects. We have postdocs, we have doc students. We've put together a nice collection of people, but more importantly, or just as importantly, we have several data sets, a large set of data lakes, if you want to call it. And that way, when someone does need a project, we can reach out to our network of clinical folks and investigators to say, here's a series of questions we need answered. Here's the data. You don't have to go and necessarily collect data, which is takes time, and get them through the process. But also, I mean, we just had an OTD student. She finished up yesterday from Corey's former institute, where she came, got clinical observation experience, but also worked on a research project. And I think the other part to that, in hearing what others are saying, is it is business. Don't call it research. It is business. But we've learned that in order to get even more buy-in from the medical center side is to call it quality improvement. That sort of changes the perception of what it is you're trying to do. You're not a research coming in saying, here's my project, can you help me do this? It's more coming in now and saying, this is what we need to measure in order to show our value, versus just making it a sort of a one-time research or thesis project. So with that, I'll just say that it's this group that has formed and continues to grow is not going away, but the LeaRRn program is what got this kicked off. So thank you.
Thanks, Mark. Dan, I have you up as a speaker for this one.
Yeah, thank you. I just had to pull up my notes here. I lost them. Yeah, yeah, this is exciting. I think we envision still participating. Our organization, national organization's mission statement is improving lives by delivering solutions for quality care. And we think the activities of embedding researchers is key to part of that process. It isn't just, saying things, but it's doing things. And I think having people do stuff and have this research advance the science and understanding and knowledge ultimately improves care. So, we want to continue the activities to have facilitate that linkage between providers and our members, as well as provide the technical support and guidance that we can give with our resources we have as a national organization. So we're excited. We're looking forward to the LTC data cooperative and increasing the capacity and its use. And I think what the future really ties into, up to now, we've sort of focused on the simple low-hanging fruit and analytics related to Medicare fee-for-service in many ways, because that's the easiest place to get data. Getting stuff from Medicare Advantage activities a little bit more challenging, and Medicaid activities, how much we tie to that isn't there. But we think there's opportunities within where we might be able to facilitate more research within our organizations. What's been happening for the past several years is, as nationally, we've established provider networks within states. So instead of just possibly a researcher working with an individual company, they'll be working with dozens to hundreds of facilities within a state that have the same common interests, the same common network, and they're together to demonstrate to payers that they are the preferred partner. So it's that business model approach. They have a motivation to possibly do research to show their business model is better than a non-provider network in their state. So that's an opportunity that's neat. What's growing also very importantly is specialized Medicare managed care plans for institutional special needs plan, which are long-term care residents or permanent long-term care residents that the SNF or a small or a managed care plan can establish for just long-term care residents, where that I-SNF controls the care. They control the bundle. They're responsible for, if they go to a hospital, they're paying that, so that they have a big interest in improving the quality of care outcomes and avoiding hospitalization. They would be an ideal partner, possibly to do research projects, aligning with the I-SNP. A little bit more challenging because it's a little bit further away and hands off, and other people own them. But alignment with ACOs. Have we explored those opportunities? And I think there's a neat future for going beyond just working with an individual provider, individual health system, but starting to tie together people that are actually competing businesses that have a common interest, that they're working together to address a common need to provide better value and outcome. And again, rehab's tied to all of that, as we know, for the long-term post-acute care population. And so we have that excitement there of moving forward with those ideas as researchers show interest in those. And if we can help facilitate that, we're looking forward to it.
Okay, great. Thanks, Tan. And we're at time, but maybe Mike will give you a chance if you have a couple of comments you want to make just briefly before we go to the Q&A. We don't have that many questions in the Q&A, so I think we have time if you can comment.
Yeah, so I think we're a little further along in this process, originally with CoStar, before that. And so when we came to LeaRRn, we're a little more mature in our questions. And I think what LeaRRn really helped us with was strategically identifying people that were accelerants for certain specific efforts or projects. But the key for us was that those were connected to other efforts that then taught us ways or infrastructure to drive those things. I think the other thing that we realize is that rehabilitation is both horizontally and vertically aligned. And essentially, we are part of every other this surgery, medicine, neuro, paint, you name it. We are a small bullet as part of their care delivery. And so what this has allowed us to do is reach out and create certain networks that can be leveraged. The other neat thing for us, and it was mentioned by Karen and Shweta, it was done at Intermountain. We have our mobility program, our ICU work that we've now seen disseminated to other organizations. And actually that was reflected back to us where we learned lessons as it was deployed in other organizations. And back to what was mentioned about networking, you now have groups of clinical operators, researchers, clinical informatics people. When we want to reach out for grants like PCORI, AHRQ, et cetera, those groups have already worked together in a certain milieu of that makes it a lot easier to come together and put work out there. In my hope, drives that academic currency, as was mentioned, but also drives what we're doing operationally and innovating in our health system, which quite honestly, I will tell you, this is from my experience going around hundreds of hospitals. I've yet to go to the hospital that tells me they have enough resources. When I find that place, I'll retire there. But no one ever has enough resources. So I think health services research overall is the necessary element to drive innovation around efficiencies in existing systems and an environment that is not interested in adding more human resources or equipment resources. I'm done.